morning, good afternoon, and good evening to our distinguished speakers, chairs, and audiences of ACNS webinars. We are back again with the first webinar in the month of August 2021, and we have two great speakers and very learned chairs to discuss and enlighten us. The first speaker for today is our honored guest from Israel, Professor Shlomi Constantini. Professor Constantini is the Director of Department of Pediatric Neurosurgery at the Dan Advek Children's Hospital, Tel Aviv, Israel. Professor Constantini has received advanced training from Fred Epstein at the New York University, specializing in complex brain and spinal cord surgical challenges in children, focusing on those that are the most difficult to operate. He is active internationally while serving roles in global organizations such as immediate past president of the IFNE, past general secretary of the ISPN, president of the ISPN in 2018, and past vice president of the EANS. Professor Constantini is intensely performing research and has published over 300 papers in peer-reviewed journals and over 50 book chapters. He is also a member of the editorial board of several journals. We are extremely honored to have him today as a speaker for webinars, and today he'll be talking about optic pathway gliomas. The second speaker for today is our honored senior faculty from China, Professor Wei Yan. Professor Yan is the Associated Chief Physician, Department of Neurosurgery at the second affiliated hospital, Zhejiang University, China. He is an expert in the field of neuroendoscopy, and we are extremely honored to have him today as a speaker for our webinars. He'll be talking about endoscopic endonasal optic nerve decompression in traumatic optic neuropathy. The chair for the first session of today's webinar is our honored guest from Japan, Professor Ryuta Sato. Professor Sato is the professor at the Department of Neurosurgery, Nagoya University Graduate School of Medicine, Nagoya. Professor Sato did his postdoc at the UCSF, California, way back, where he researched on convection enhanced drug delivery in the management of gliomas. He continues his interest in neuro-oncology in his institution, and we are extremely honored to have him today to chair the first session of Professor Constantini. The second chair for today's webinar is our honored guest from the United Kingdom, Professor Ramesh Nair. Professor Ramesh Nair is a consultant skull base and neurovascular surgeon, head of the skull base and neurovascular surgery at the Charing Cross Hospital and St. Mary's Hospital, Imperial College Healthcare, NHS Trust, London. Professor Ramesh is the executive editor of the Asian Journal of Neurosurgery and the associate editor of the British Journal of Neurosurgery. He is an invited faculty of the ACNS as well as the WFNS educational courses. We are extremely honored to have him today with us to chair the second session of Professor Wei. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the audiences to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to the first chair, Professor Ryuta Sato.
Hi, good evening. And now it's good evening in Japan. It's 9:30 in the evening. But my name is Ryuta Sato. I'm a professor at Nagoya University in Japan. First session is about the optic pathway gliomas, and I have 5 minutes. I have 5 minutes to summarize this disease. Optic pathway gliomas are relatively uncommon tumors with a variable clinical course. They are often seen in the setting of neurofibromatosis type 1, and historically the majority of the tumor is parasitic astrocytomas. Treatment varies with the location of the tumor. If it is isolated to one optic nerve and does not extend to the chiasm, then resection is curative. If a tumor extends to the chiasm or more posteriorly, then curative resection is not possible, with resection reserved for treatment of mass effects. In these cases, chemotherapy and radiation therapies are treatment of choice. For chemotherapy, platinum-based regimen is often used. Many reports that chemotherapy helps preservation of vision in the majority of children. There is also a report that early radiation therapy preserves vision in sporadic optic pathway gliomas, even in pediatric cases. Anyway, I think chemotherapy with or without biopsy and debarking surgery when necessary may be the golden standard in management of optic pathway gliomas. Today, we are going to have a lecture about management of optic pathway gliomas from Dr. Shlomi Constantini. Dr. Constantini, would you please start your lecture?
Thank you very much. I'm going to share my screen now. All right, so this is my assignment, optic pathway gliomas, OPGs, classification and and insight. I'm here representing not only my hospital, but also the Gilbert Israeli Neurofibromatosis Center, on which I'll speak a little bit later. So this is the most common primary neoplasm of the optic pathway. It represents about 1% of all brain tumors in adults, about 5% in children. It's more amongst neurofibromatosis patients, where it is present in about 1 in 5 of the patients with NF1. So what are the clinical facts? It's mainly an indolent course. We will challenge this concept, especially in neurofibromatosis patients. Perhaps it is more indolent than on sporadic cases. About a third to half will cause clinical symptoms. The common ophthalmological symptoms are proptosis, visual loss, optic nerve atrophy, and abnormal pupillary function, but also precocious puberty and hydrocephalus. So there are a couple of questions that I would like to pose at the beginning of the talk. Do we have a good classification system? How to follow these children? When and who to treat? How to treat? Can we predict prognosis? So is this the same disease? On the left, you see a patient with severe bilateral, isolated optic nerve tumors with bilateral proptosis. And on the right, you see a classical case of neurofibromatosis where the disease spreads backward to the posterior optic pathways. So they don't look the same. They look very different, those patients. It is a very heterogeneous disease, as was posed here in the beginning in the introduction. So the basic classification of OPGs was put more than 60 years ago by Dodge. There is a modified Dodge that came up about 13 years ago, and there is a new staging classification, we call it the Tel-Aviv staging, that I will dwell a little bit about. The Dodge classification is only good for research. It does not change over time. It does not change even if there is a radiological progression, and even if there is a clinical progression. There is a poor correlation between the Dodge classification and the clinical and ophthalmological status and prognosis. The modified Dodge is too complicated. It has the same difficulties. We need a better staging system. So this is our offer, the Tel-Aviv classification. There are a couple of yes-no questions. Neurofibromatosis, yes, no. The age at clinical presentation is very important. Those who present early are worse. And then the anatomy. Is there involvement of the posterior optic pathways? It's a yes, no. Is there involvement of the optic nerve itself, not the chiasm? Yes, no. And when it is involved, is it an isolated optic nerve disease with or without the chiasm involved? And then chiasmatic involvement has 4 stages. Of course, the molecular markers play a huge role, as we will discuss a little bit in a way. So this would be stage 1 in terms of chiasm involvement. So stage 1 would be only the chiasm is involved. Stage 2 would be chiasmatic tumor, but growing up into the hypothalamus. Stage 3 would be chiasm, but growing up into the 3rd ventricle, as you see here. And stage 4 would be a major supra and paracellular involvement of the optic pathway tumor. I want to show you an example. This is a 15-year-old that presented with blindness on the right. He was actually blind for a while. He never complained. This is one of the problems when you deal with children, is that they do not complain. This is what we call la belle indifference. This, of course, makes diagnosis in children more challenging than it is in adults. So he presented with this tumor and blindness on the right side. So this tumor clearly is epicentered in the hypothalamus. Is it an optic pathway glioma? It's not epicentered within the optic pathway. So there is a mixing between the hypothalamus and the chiasm itself. So this tumor would be a grade 4, according to our classification, with involvement in the third ventricle and the subarachnoid space with some cystic elements. And this is, the photo you see here is after removal of the tumor, where you see, of course, the carotid and the bifurcation and the chiasm and the basilar. And this is after removal. I left a piece within the chiasm that was embedded into the chiasm. So this is him a day after the surgery. So this is before the surgery. And this is now. This is, this is about 20 years, about 20 years later, he has this residual that never grew over time. He never received chemotherapy or radiotherapy for this residual. So it was probably a good idea to leave this tumor behind and leave an intact boy. Of course, his vision on one eye never came back. This is an optic nerve tumor. As you can see here, there's a tumor inside the orbit. It's an enhancing tumor without involvement of the chiasm. We call it IONG for isolated optic nerve tumor. It may present when they are very large. It may present with blindness and proptosis. And many, as I said before, are isolated. And this one involves the nerve and the chiasm bilaterally. So this is the IONG study, the isolated optic nerve study from 2016 that was published. You can look it up. We looked at 34 patients. The average age of diagnosis was 6. The average follow-up time was 6 years. There were 22 neurofibromatosis patients. And I summarized to you the conclusions for the isolated optic nerve tumors. It's a highly active tumor, and about 50% will progress over time. Spontaneous regression is possible, but extremely rare. Devastating visual outcome. It may respond better to chemotherapy than the general optic pathway tumor. Look at this case. Chiasmatic thickening, non-enhancing. I worry of these tumors. They cause fast visual problems. And look at this tumor with major supracellular involvement and a cystic cavity. You know that if you will biopsy them, they're all going to be low-grade astrocytomas. Most of them would be juvenile polycystic astrocytomas. And this tumor growing all the way up and causing hydrocephalus. And this tumor that I showed you before in a neurofibromatosis patient with extension backwards into both posterior pathways. Now, the neurofibromatosis patients are difficult to evaluate because there are all these what we call neurofibromatosis associated changes. They can be in the brainstem, in the cerebellum, along the optic pathways. Most of them are non-neoplastic. You may have in NF patients an enlarged nerve sheath, and the optic nerves may be tortuous, but not necessarily neoplastic. So the initial evaluation of an OPG patient, first we should screen all NF patients. We've passed the period when there was a notion that NF patients should not be screened until they develop symptoms. Well, we like to screen them because if you find something, your eyes will be focused on the finding and your follow-up will be better. So you do a baseline neuro-ophthalmological exam, including visual acuity, visual fields, the OCT, the fundoscopy. You get a neurological exam. Of course, you get an MRI of the head and the spine. You get an endocrinological evaluation. You get a neurosurgical evaluation. This is classically a multidisciplinary team, as you can see on the photo on the right side. Now, this is a slowly progressive disease. So one of the sins that we're doing is to compare each MRI and each vision to the last exam. And then you see really you have limited view on what is happening, when in fact, you need to look at the outcome over a long range of time before you make oncological decisions. Always look at the broad picture. Now, how to follow radiologically? Every 6 months, perhaps every 3 months in the first year, and then every 6 months to 1 year. Linear measurements of these tumors are error prone, and volumetric measurements are time consuming. There is no correlation between imaging and vision. We need better imaging for follow-up and natural history, for surveillance of treatment, and for understanding the anatomy-pathology relationship. So we have published extensively on what we call automatic segmentation, classification, and follow-up of optic nerve tumors. Look at this case. What do? How do you measure? Where do you put the line diagonally? How do you make sure that when you do the follow-up exam, the linear measurements are going to be exactly at the same angle? So we have developed this 5 steps method. First, we do an Interscan co-registration, then an Interscan co-registration, then we do segmentation, which is semi-automatic, then we do an internal sub-segmentation, and we see the course over time. So this would be a case. The step 1 would be to take the T1 and T2 and slice them to have them exactly at the same angle and mark the tumor. Then this is the baseline exam. This is the follow-up exam. It's not in the same diagonal angle. So you take the follow-up exam and you shift it, you change it so that you can follow better and you can compare better. Then you do the automatic segmentation. There are a couple of applications to do it. So you take the baseline exam. This is the follow-up exam where you move the demarcation of the baseline exam to it, and then you get the follow-up exam with the corrected demarcation, and you see the dynamic of the tumor. This was the next stage, to take the demarcated tumor and then to divide it into solid enhancing, solid non-enhancing, and cystic tumor, and then to see the volumes of these 4 different components. So when we sit in an oncology meeting, we see this graph. This is an individual patient. Each one of these points at the base is 1 MRI, and every one of them is sub-segmented into the different components. On top of it, you superimpose the oncological treatment so that when you look at a single patient, you can understand the disease better, much better than comparing a scan to the previous scan. So the NF patients have a better prognosis. The bad prognosis is associated with sporadic gliomas, with posterior tumors, with progressive tumors, and with age at less than 1 year at diagnosis. Is it really an indolent tumor? Not always. Look at this demonstrative case. This is a 4-year-old male with NF1, OPG on routine screening. You see it very clear. And then a rapid visual and radiological deterioration over 4 months. Then he got the first chemotherapy initiated. The first chemotherapy was with vincristine and carboplatin. He failed after 11 months. Because of severe carboplatin allergy, the treatment was stopped. So he was moved to second-line chemotherapy. Second-line chemotherapy with vinblastine. He continued to deteriorate both on a radiological and visual fronts. So we shift him to third line with rapamycin and Tarceva. We have a paper on that, on rapamycin Tarceva for OPG. And this is the patient with the outcome perspective. You see his vision going down and his tumor going up. Interestingly, his right hand changed from hand movement to no light perception. His left hand changed from 6/36 to 6/2016. So not that indolent, not indolent. Interestingly, the Dodge and the modified Dodge classification did not change over this period. And this is what happened. Look at those serial MRIs. The tumor starts to grow, to have cysts inside and the outside of the tumor. Very difficult to control this tumor and to prevent blindness. Who should receive treatment and what kind of treatment? So dynamic patients are patients who have 2 lines decline in the slannel, patients who have a radiological progressive tumor, what about those who have an MRI change but a stable vision? Should we treat them? We don't know. There is a debate. How much did it grow? At what age? Are we treating our patients too late? You'll see our results in terms of vision preservation. They're not that great. So how to treat? With oncology, we usually give chemotherapy, and lately we're giving more and more biological treatment. Radiation is considered a no-no for NF patients, but is there a safe age for NF patients? Of course, they're more prone to secondary tumors and to moya. But do we underuse radiation for non-neurofibromatosis optic pathway gliomas? Remains an open question in surgery and future direction. So surgery can be by biopsy. Well, the biopsy for OPG is a matter of debate. Patients with NF1 usually do not require biopsy because they are positive, and usually we respond well to biological treatment. For non-NF patients, if the MRI is classical, most people would skip the biopsy. Does it really make a difference if it's a JPA, a low-grade glioma, or a pilomaxoid? Well, what makes a difference if it's BRAF positive? Then biological treatments can be kicked in. Most oncologists would not give the brafamide and MEK inhibitors when they don't have a biopsy. This may change over time. And of course, you've got to be careful not to miss a germ cell tumor, which is in a differential diagnosis of supracellular tumors. Well, the biological markers are extremely important. As we try them more and more, we see very positive results. So that's about biopsy. About surgery to resect tumor, there's very poor data. And what about the small chiasmatic lesions? They usually cause blindness. There is no surgery for the small chiasmatic tumor. So I'll give you an example. This is a 4-year-old boy with a sporadic glioma. We can call it a chiasmatic hypothalamic tumor. We referred and for surgery and did a subtotal resection followed by mild hemiparesis. And then there was a residual at the chiasm. He received chemotherapy with vincristine and carboplatin, and the tumor disappeared. And now he has stable residual tumor. It's already 8 years. So maybe we should have started with chemotherapy on this patient and avoid the surgery and avoid the hemiparesis. This boy, by the way, improved his vision with chemotherapy. Look at this case. This is a 20-month-old female presented with head enlargement and full diencephalic syndrome. She weighed 4.5 kilos. She had optic atrophy, and MRI showed this huge supracellular lesion with hydrocephalus with this foamy appearance with little cysts inside. We took her to surgery and performed a subtotal resection followed by a shunt. She's incredibly stable and well on chemotherapy. And look what we did in surgery. We did exactly what we planned to do. We took the upper part of the tumor and left the lower part with the chiasm so that we don't interfere with the chiasm. It is impossible to identify the chiasm as you go into surgery. This is a cyst-loving optic pathway glioma. We had 10 operations already to drain the cyst. Just the cyst is not pure CSF. It has mucinous, gelatinous fluids, very difficult endoscopy catheters to prevent a gradual visual decline. So there are open surgical questions. Do we need a biopsy for sporadic patients? Is early surgery beneficial? What is the optimal extent of resection? And what is the role of surgery in isolated optic nerve tumors? Well, chemotherapy, we start with vincristine and carboplatin. This is the Packer protocol. If there's allergies, we move to vinblastine. Then there is a second line with temozolomide is being used more and more. And then the oncological open studies, rapamycin, Tocilizumab, Avastin, irinotecan, MEK inhibitors, and anti-BRAF medications. Does chemotherapy really affect the visual outcome? So we followed the study by Perilongo from 2007 by our study from 2011. This is a study by my student, Ben Shofty, who showed disappointing results for chemotherapy of both vision and tumor. To summarize, we looked at 19 patients who received chemotherapy for declining vision. Under chemotherapy, 14 deteriorated, 4 remained stable, and only 1 improved. Very, very disappointing. What about radiotherapy? As we said, it's not recommended for NF1 patients as a rule because of cognitive impairment, secondary tumors, and vascular sequelae. But few supporting evidence for stereotactic radiosurgery for proton beams. But look at this data from Tom Merchant from St. Jude in Journal of Clinical Oncology, 2009. Patients who received radiotherapy. This was NF1 patients with sporadic gliomas. The vision remained stable or improved in 2/3 of the patients. So we may be underusing radiotherapy for optic pathway gliomas in children, at least children above the 8 or 10 years of age. Who should we irradiate? Is there an NF1 safe zone in terms of age? What is the role of proton beams? What is the role of stereotactic radiosurgery? What about optic pathway gliomas in adults? We looked at 22 adult patients with OPGs. This is a paper in neurosurgery that was published a few years ago, again by Ben Shofty. And the conclusion, we have patients who had progression as a child and drifted into adulthood. And we had a few patients that were diagnosed at adulthood. Those that were diagnosed at adulthood, they had 50% progression, consider radiation, and half of them were high-grade gliomas, very different from the pediatric population. So I want to thank my partners, especially at the Gilbert Israeli Neurofibromatosis Center, where we have over 2,000 patients with NF1, NF2, tuberous sclerosis, and von Hippel-Lindau. Well, decisions are difficult. This I picked up in the Prado in Madrid. Jesus among the doctors. It would be nice to have somebody that we can ask for advice when we don't really know what to do. We are an international department. You're all invited to visit us in Tel Aviv, and this might be a good excuse, the AACNS in Jerusalem in September 2022. You can all write to me on my private email. Thank you very much.
Thank you very much, Dr. Constantini. It was a very, very helpful talk. Thank you for the great talk. Is there any questions from the audience? There is one. I'll read the question. Youngest age at which you give radiotherapy? How much chemotherapy really helped to reduce tumor mass?
Right. So the radiotherapy, the medical oncologists really hate radiotherapy, and they have a good reason. I think now that the results of radiotherapy that was delivered during the 80s, the 90s, and even the 2000s should be very different from the results of radiotherapy given today with IMRT or with protons, because the delivery of radiation to the surrounding brain is going down and down. There's never going to be radiotherapy as first line, but those who failed chemotherapy, first line, second line, I think we should irradiate them before they get blind. Because as Tom Merchant says, there is a momentum. So you cannot take a patient who has a couple of axons left in his optic nerve and irradiate him and think that he will improve. Send them before they're blind or pre-blind. And I think never below the age of 8 or 10.
Thank you very much. And about the chemotherapy, you use vincristine and carboplatin first for the first line. And
Yes.
the second line will be temozolomide?
Yes, vincristine and carboplatin is the famous Kurodu-Peka paper from 1987. This was considered first line, always. Now, there are challenges, and the challenges is, should we give, especially in NF1 patients, biological treatment with either dabrafenib or MEK inhibitors, or both of them together as first line? So it's a moving target. At the moment, most centers would start with vincristine carboplatin and reserve the biological treatment for those who fail. But there are open studies to give biological treatment as first line.
Okay, thank you very much.
Thank
I think you mentioned the case which you treated, which you did the surgery first, and the tumor stayed stable afterward. What do you think is the difference
Well,
between
we
the
don't know.
aggressive tumor and a non-aggressive tumor?
Well, this is a huge question with pediatric low-grade neuroglial tumors. Occasionally, you do a subtotal resection and the residual never grows. We do not know to predict which one will grow and which one will not grow. So usually, when we do subtotal resection on any neuroglial tumor in a child, we follow the residual and we reserve treatment for those who grow.
At first touch, do you recommend chemotherapy first or the surgery first when the tumor is not, you know?
I think surgery should be reserved to biopsy when your oncologist demands it, one. To CSF pathways by either shunt or endoscopy or combined septum pellucidotomy, and to debulking of those major hypothalamic tumors that grow up, especially in infants. But I have to tell you, I asked myself many times whether surgery is indicated at all, because the infants are those that react better to chemotherapy. As you grow older, the chances that you will react to chemotherapy are smaller. So when the mass is huge, you can reduce the mass and use combination therapy. It's not one tool, it's combining several tools.
Okay, thank you very much. About the classification you mentioned, you're going to, present as your classification?
Yes, this is sitting on my desktop for the last 6 months. I need to write it up. I think we need it because we need a common language, because there are papers on OPGs and this is so variable. As you said in your introduction, so heterogeneous. So comparing an isolated optic nerve glioma to a major hypothalamic tumor does not make any sense.
Yeah, I agree with you.
Thank you.
It will be very helpful if you give us the opportunity to use your classification and maybe for follow-up and also for treatment. It will be very helpful for us.
Thank you.
Thank you very much for the great talk. It's still, we still have time, but is there any question from the audience?
One question from Dr. Ajit R, who is here. Yes, Dr. Ajit R, you may kindly ask Professor Ajit R.
Okay, thanks for the wonderful presentation regarding the optic gliomas. My question is regarding a practical point. What is your plan of management in a child who have a pyrocytic astrocytoma? That is, by biopsy it has proven, and it doesn't have only minimal visual defect, and it is a huge one extending into the chiasm, hypothalamus. What is your plan of treatment? Because if you do
so you're saying it's a child, what is the age?
13, 14 years.
Any symptoms at the moment?
She has some field defect, but practically it's only by perimetry we have find the field defect.
Is it progressive?
But I have only followed for only 1 year, not considerably becoming large.
I'll tell you,
growing.
I understand the dilemma. You have options here. The options are between a watchful following and then taking a decision if the tumor grows. This is one option. And the other option is to treat. Now, at the age of 13, the chances that chemotherapy will work is very, very small. It's probably below 20%. So now the question is, what is the BRAF and MEK molecular biology? If the V600 and the BRAF molecules are favorable for oncological treatment, and you do decide to treat, this would be a good option as well.
Right.
There is no surgical intervention needed at this point.
Well, that for the surgical intervention, you need to see the specific individual anatomy.
Okay.
There is surgery, of course. For tumors who grow into the third ventricle, you can do it. For tumors who grow subfrontally, you can do it. For tumors who cause hydrocephalus, you can do it. But if the origin is in the chiasm, you've got to be very, very careful, because you do not see when you resect, when you enter the chiasm. So I do not say no surgery. I just say pick your cases very cautiously.
Right. Thank you very much.
Thank you.
Any questions from Professor Ramesh Nair?
No, I was glad to see Ajit. It's been a long time.
Yeah. Yeah.
Okay, thank you very much. With that case, we'll wind up the session. The final comments from Professor Yuta Sato.
Thank you very much for the great talk, and thank you very much for the opportunity to chair this meeting. It was a very great talk, and it was very helpful for us. We manage many optic pathway glioma patients, and usually we do chemotherapy first and do surgery when needed. But radiotherapy may be more. We should consider radiotherapy more earlier to preserve the optic function. So it was very nice talk. Thank you very much, Dr. Constantini.
Thank you very much.
Right.
Before we
you.
go on to the second session, I would like to inquire whether Professor Constantini would be staying back for the second lecture.
No, I have to leave. I have surgery that started already. I apologize.
Thank you. In
gotta
that
go.
case, thank
Nice
you
talking.
very
Thank
much.
you much.
May I kindly
you,
inform
guys.
that there are 1,020 people who are watching this live today
Crazy stuff.
from China,
Thank you.
India, and
It's
most
a
of the parts
pleasure.
of the world. Thank you
Big
very
honor.
much for this wonderful
Thank
lecture.
you.
With
Thank
that, I would like to hand over this session to the next chair, Professor Ramesh Nair.
Thank you. Thank you, Raja, and thank the ACNS. And it's a great honor to be invited to chair the great session of eminent speakers and prominent neurosurgeons with a lot of experience in various complex conditions. The next talk is on endoscopic decompression of the optic nerve in traumatic optic nerve injuries. I think it is a very critical topic, because we do see a lot of patients with that condition, and also endoscopic management of optic nerve is a serious factor, because we treat many patients for non-traumatic conditions as well, such as meningiomas or osteofibromas, and sometimes even compression from other infectious conditions like granulomas. And so at the role of optic nerve decompression in traumatic optic nerve injury is sometimes can be a bit controversial. I don't think there is a clear sort of algorithm or protocol for such patients, and the dilemma comes when there is no sort of a consensus about when to operate this patient, whether to try steroids or not, and how late can you operate, and what is the outcome, and how soon, what sort of procedure you have to do. These are all whether to decompress the optic nerve with the analysis of zinc. These are the things which are critical when talking about this. And also the optic nerve injury is often unrecognized, and patients may not be alert enough to tell their symptoms that they are having visual problems or visual loss, and then you often recognize it a bit late. So I'm very keen to hear from Prof. Yan, who's from Xianji. I think it's Xianjiang, the university hospital. And thank you for talking to us today. And I am very keen to listen to your talk. Thank you.
Thank you. Okay. Thank you for your introduction. Good morning, good afternoon, and good evening, everyone. Now it's 9 p.m. in China, and it's really my great honor to have the opportunity to share our work on this topic. As the professor mentioned, the research for this topic is controversial now, but today I'd like to share our experience for the endoscopic endonasal optic nerve decompression in traumatic optic neuropathy. As we all know, traumatic optic neuropathy is an acute injury of the optic nerve with impairment of visual function. In the literature, about 0.5 to 5% of severe head injuries will have a concomitant injury to the optic nerve, optic tract, or optic cortex. Although it is really an uncommon condition, but the possibility of traumatic optic neuropathy should be considered in all cases of cranial or maxillofacial trauma. Some also believe that the early diagnosis and treatment of TON may be of greater benefit to the patients and advocate diagnosis of optic nerve deficits by the presence of absolute or relative afferent pituitary defects. But unfortunately, up to now, there's no standard treatment protocol for this kind of patients. In literature, the therapeutic recommendations are various, from the simple clinical observation with no treatment to the medical therapy, and even to the surgical decompression, and finally to the combination of these two options. The best treatment for TON remains controversial because the pathophysiologic mechanism involved is very complex. With the development of the techniques and equipments, endoscopic endonasal surgery increase its field of application. More and more research suggests that this operation may do benefit to TON patients. So today, I'd like to share the experience in our center. In our center, the patients, TBI patients with severe VA visual acuity decline or severe visual field defection will be treated with both surgery and steroid treatment. We definite the severe visual acuity decline as below the standard logarithmic visual chart 0.1, and we definite the severe visual field defection as the defection is more than 50%. From the June 2017 to present, we have performed more than 200 cases with this surgery. In our opinion, for this kind of disease, I think there are at least 3 key points we should consider. The first question is that, should the surgery be performed for TON patients? In fact, that's a question about the effect of this surgery. And the second question is, what kind of TON patients will get benefits from this surgery? In fact, that is a question about the surgical indication and surgical timing. And the third question is that, how can we elevate the surgery effects. It's a question about the surgical tips and tricks. So let's come to the first question. Why in our center we choose this operation to treat TON patients? There are many reasons. The first reason is that, in our opinion, this surgery is fully consistent with the pathophysiological mechanism under TON. As we all know, TON can be divided into direct TON and indirect TON. Indirect TON often results from the shock wave induced secondary damage to the optic nerve due to intraneural edema, occlusion of microvascular and CSF circulation, and interruption of the direct exoplasmic transport. Theoretically, optic nerve decompression reduces the intracanaliculaar pressure and allows for the removal of any impinging bony fragments, assisting in the re-establishment of nerve function. So that is the first reason. And the second reason is that in clinical practice, many cases give us confidence for this surgery. Here, I'd like to show two cases with you. The first case is a 38-year-old male. He suffered from traffic accident and suffered from visual acuity decline post-injury, and his visual acuity is light perception on the left side eyes. In local hospital, the doctor gave him steroid treatment for 4 days, but no improvement, not any improvement was get. And when the patient transferred to our hospital, we do the operation, and 2 hours, only 2 hours post the operation, the patient can see the finger at a distance at about 2 meters. So it is really magic effect. And this is a picture of the patient. We can see the fragment of the bony of the optic canal here and here. And we can also see the fragment at the fracture on the coronal CT scan. This is the scan post-operation. And this is what we see during the operation and the endoscopy. We can see the fractured bone clearly here. And this is the picture after the decompression. Here is the second case. This is a 37-year-old female, also male, sorry. And he fall down. And when he was transferred to our hospital, it is 3 days after the 3 days after the accident. And we can see the picture of the patient. So here is the results. This is a visual field test of this patient. The left one is the visual field test of the left eyes pre-operation, and the right one is the test after operation. There is only 3 days duration, so we can see that the visual field impairment has significantly reduced after the operation. This really magic effect, I think. So more and more cases give us the confidence on this operation. So we do analysis for the case series in our hospital. And we do a retrospective study, include 72 TOM patients who underwent this operation from August 2017 to May 2019. And we can see that after the operation, the visual acuity of patients is improved significantly. In fact, more and more research support our results. This is publications on this topic. And most of the results is that this operation can do benefit to the TOM patients. So, unfortunately, the fact is that there are rarely some patients will not get any benefit after the operation. So let's come to the second question. What kind of TOM patients will get benefit from the operation? It's a question about operation indication. I think that's really this question is the most important during we treat this kind of patients. So we do some research and publish some articles on this topic. All of these are our team's work publications. Let's also go back to the 32 patients we analyzed. This is the clinical characteristics of these patients. And this is a method we assess the visual acuity for this patient. So, what factors will be important for the outcome of this patient after surgery? And the first picture shows the relationship between the outcome and the pre-operative visual acuity. The improvement rate of patients with reduced vision and no light perception was 83% and 33% respectively. So we can see that there is statistically significant differences between the patients with reduced vision and no light perception. So the first thing is that the pre-operative visual acuity plays an important role on the outcome of the patient. The second picture shows the relation between outcome and operation time. This is a comparison of surgery improvement rate between patients who received the surgery within 3 days, 3 to 7 days, and later than 7 days. The improvement rate of time to surgery within 3 days, 7 days, and later than 7 days was 30%, 31%, and 60%, 61%, and 35% respectively. Statistically significant difference was also detected between patients who received surgery within 7 days and later than 7 days. So we can see that operation time also plays an important role in the patient's outcome after surgery. Furthermore, we do more research about the patients with no light perception. This is a picture comparison of surgery improvement rate between patients with no light perception within 3 days, 3 to 7 days, and later than 7 days. The improvement rate of blindness patients, all of patients are blindness before the surgery. The improvement rate of blindness patients who underwent surgery within 3 days, 3 to 7 days, and later than 7 days was 50%, 37% and 0 respectively. And the improvement rate of patients with no light perception who received surgery within 3 days and 3 days to 7 days was significantly higher than that of patients who received surgery beyond 7 days. In our case areas, no patients with no light perception get benefit from this surgery after 7 days after the accident. So we can also see that among the significantly improved patients with no light perception who received surgery within 3 days, and the VA improved obviously and improved to figure counts in a significantly higher number than no light perception patients who received surgery beyond 7 days. And the last picture is a comparison of surgery improvement rate between the patients with residual vision received the surgery within 3 days, 3 to 7 days, and later than 7 days. The effective rate of patients with residual vision who abandoned intervention within 3 days, 3 to 7 days, and later than 7 days was 85%, 92%, and 70% respectively. For these patients, there are no significant differences regarding different surgical times in our case areas. In fact, our results, many research get the similar results from our research. This is a meta-analysis for many qualified research. So we can see from the picture that the vision improvement rate between patients with no light perception and better than the no light perception pre-operative. With visual residue, the patients will get a better outcome than those patients with no light perception. So, in our opinion, the surgical indication in our center is the patient has a TBI history and he or she has severe VA decline or VF definition, defection, and no significant improvement after steroid treatment. Of course, we should exclude other reasons for the VA decline. This kind of patients should get surgery in our opinion. How about the surgical time? For the patients with no light perception, we suggest that the operation must be performed within 3 days. If it can be performed within must be performed within 7 days. If it can be performed within 3 days, the patient may get a better outcome. For the patient with residual vision, we state the suggestion that the operation should be performed within 28 days. And for those performed within 7 days, the patient may get a better outcome. So let's come to the largest question. How can we elevate the surgery effects? It's a question about the surgical tips and tricks. As a neurosurgeon, especially the endoscopic surgery, we are familiar with pituitary adenoma resection. So most of doctors are familiar with this transsphenoid approach. But for TON patients, we suggest to choose the transethmoidal transsphenoid approach, because by this approach, we can see the whole length of optic canal, and also we can see the orbital apex, which should be decompressed during this operation. By the way, use this approach, we don't have to resect the middle turbinate, which can result bleeding after the operation. The second thing is the scope of decompression. I think it is very important. Most doctors suggest that the scope of decompression should include the whole length of optic canal. And recent years, doctors also suggest that the orbital apex should be also decompressed. In our opinion, that's not enough. We suggest that we also remove the bone of tuberculum cellae and also the part of the optic struts, this part. Why? We remove this part of bone in order to decompress ophthalmic artery, which starts here and go to the eyes. We think for the decompression, for the protect of the nerve, we should not only decompress the optic nerve, we should also decompress the ophthalmic artery. This is important. Here are some examples. So on this picture, we can see the fracture of the optic canal. The picture A is a pre-operative CT, shows the optic canal fracture here. Here is a fracture. And the picture B is post-operative CT. And the picture C is the pre-operative coronary CT. We can see the optic canal fracture locates on the superior wall of the optic canal. And here, picture D is a picture after the operation. We can see the fractured bone was fully removed. And here is the typical MRI imaging of TON before and after the surgery. On the picture A, we can see the preoperative horizontal MRI shows the compressed optic nerve here. The nerve is compressed by the bone. And here, picture B shows that post-operative, the optic nerve is fully decompressed. These are the pictures during the operation. Picture A, we can see that optic nerve partly decompressed. And here is the bony fragments. After we remove the fractured bone, we try to detect the artery. Picture B shows the we use Doppler to detect the internal carotid artery position. And picture C, we try to use Doppler to detect the ophthalmic artery. If we can detect the ophthalmic artery, we think that we got enough decompress for this artery. And picture D we can see that optic nerve sufficiently decompressed. Here is another case, another patient. I'd like to show the operation video to you. We can see the fracture here, the fracture bone here. When we drill the body of the optic canal, we should give the water to reduce the temperature of the optic canal. I'd like to show the scope of decompression to you here. Here, the fracture bone on the ICA. So here is the scope of decompression, not only the optic canal, but also the orbital apex and the lateral OCR, the optic struct. So when we move, after we remove this part of bone, we think that the ophthalmic artery could be fully decompressed. So this is the scope of the fully decompressed of optic nerve in our center. So I'd like to do a conclusion of my topic. The first thing there is that the endoscopic transnasal optic nerve decompression with steroid treatment might be helpful for the TON patients. The key factor for the outcome of this kind of patients include the baseline visual acuity and the surgical time. We suggest the fully decompression of optic nerve, which include not only the optic canal, but also the not only the optic nerve, but also the ophthalmic artery. Thank you.
Thank you very much. I think that was an excellent talk. You clearly described your experience with such a large number of patients, 72 patients in almost 2 years' time, who underwent endoscopic decompression of the optic nerve and traumatic optic nerve injuries. And you took us through the indication and which patients could benefit and how do you select the patient, and also showed us some of the surgical aspects of it. And as you say, the debate is still out there, and the question about whether this is beneficial in many patients or not is still debatable. And there are some Cochrane review which also you mentioned about it, with the benefit from observation versus steroids versus endoscopic treatment. Overall, you put forward a strong argument to consider surgical decompression in selected cases. I find that very sensible. And do you, some of the cases you mentioned, do you still operate if you don't see any fracture, but patient still got visual acuity disturbance or visual field deficit from an indirect optic nerve injury? Is that something which you would consider if you don't even see any fracture on the skull base? Professor Vian?
Oh, yes, that's right. I think that there are two conditions. The first is that we don't see any fracture on the preoperative pictures. But when we do the operation, there is in fact fracture. That's one condition. Another condition is that there is really no fracture during the operation. But I think for this kind of patients, this operation is also useful. We can think that for the head tumor patients, some patients don't have a bone fracture, but the ICP is really high. So the decompression is also helpful for this kind of patients.
Yeah, I think good point. You almost is similar to a closed head injury where you can imagine that the optic nerve, which in the canalicular portion is in a very tight compartment, and it's almost like as your similarity to the closed head injury is quite relevant, I think. The other thing which I wanted to ask is, especially if the kind of optic nerve decompression is quite a wide decompression, including the orbital wall and part of the canal, and more proximally towards the tuberculum, and also to decompose the optic nerve, especially with multiple skull-based fractures around that area. Is there any concern about carotid damage, even preoperative, which is so? Is CT angiogram is something which you do as a routine, or you only do it when there is an extensive fracture? CT angiogram for such patients is something which you would consider in all patients or in selected cases, Professor VN?
You mean any
damage? And any CT angiogram, are you concerned about any carotid artery injury in such patients?
Okay.
Also?
Yeah, that's really a very important question, I think. Some patients, in our series, we find 2 cases with artery damage before the operation. So if the patient have a severe head tumor, we'd like to do a CTA before the operation. And in our series, we don't have artery damage during the operation, but we do find 2 patients had artery injury before the operation by CTA.
Yeah, I think that's a very crucial thing to look out for, especially people who would like to consider this operation for traumatic optic nerve injuries, to make sure that there is no carotid artery damage from the fracture itself. The other thing which I thought was, always logically thinking, you always think about decompressing the optic nerve as early as possible, but I was surprised and also pleasantly surprised to hear that you could do it within 3 days or even 7 days. And those patients with some residual vision, you could even do it within a month time, which is really a surprising finding. What do you think about that? Do you have any comment about it, Professor VN? That you don't have to straight away go and do this decompression. You wait for 3 days with the steroids, and then only if the patient doesn't get any better, you go and do the decompression. That's your policy, right? That's your policy, Professor VN?
In our center, if the patient comes to our hospital, we will give him or she steroid therapy first, and we will observe whether the patient gets benefit from the treatment. So if the visual acuity get better gradually, we will keep observation. But if the visual acuity stop, get benefits, and it's still in the serious scope, we will do the operation.
Okay.
So
understand.
Yeah, we combine the 2 methods together.
Okay, that's quite reasonable, I think. And the other thing which I was wondering, especially with this fracture, is often you will have some CSF leak, and also you are decomposing the optic nerve quite extensively around the optic nerve, including taking the optic strut. Do you tend to use any sort of flap or anything to avoid any leak or exposure of the optic nerve to the sphenosinus cavity? Do you use any covering for the optic nerve, like using a nasoseptal flap after the operation?
Yeah, about 10% patients has CSF linkage pre-operation. CSF linkage concomitant with optic nerve injury together. And another 10% CSF linkage occurred during the operation. For patients with CSF linkage, we will use a nasal flap to repair the skull base. And if the linkage is serious, we also do continuous lumbar drainage for this kind of patients.
Oh, I see. Okay, thank you. I'm not sure, Raja or Liu, any questions from any of the panels or from YouTube, but overall, I think this was quite a useful talk. It's very well received everywhere. The one other thing which I want, you don't routinely use navigation for these cases, do you? Or do you use navigation?
At the beginning, I do this operation, I use navigation, but now I don't use navigation.
Okay, I think that's...
most of the patients don't need navigation.
Thank you.
Thank
All
you.
right, unless there's any further questions from anyone else. Raja, anything else?
Thank you very much, first of all, Professor Vian and Professor Ramesh Nair. It was a very interesting topic and a wonderful discussion. We have covered most of the things, but as Professor Vian said, that waiting and watching is their first choice in traumatic optic nerve injuries. But many times patients may not be conscious enough where we can assess the visual acuity. What is your line of choice in those patients? In patients who have a fracture, who have a GCS of say 12 to 13, they may not be so conscious enough where the visual acuity can be determined accurately. In that cases, what is your opinion?
May I give some
Yes,
comment
please.
before Prof. Vian speaks? I think it's a very valid question because this is a common scenario. You don't know whether the patient is alert enough to tell you the visual acuity. So all these patients should have a proper ophthalmologic examination, and somebody with a pupillary afferent defect which indicative of an optic nerve damage along with the CT finding, I think you have to consider that there is a visual problem. Of course, if the patient is alert enough and can tell you about the visual acuity, that's fine. But as you say, many patients are not in that situation, so you have to have a proper clinical examination, examine the fundus. Maybe you may have to get an MR scan to look for any swelling or any intra-optic nerve hematoma or orbital hematomas. But also, I think clinical examination with like a Marcus gun pupil or swinging flash test, I think is quite relevant to look for afferent pupillary defect. Anything more to add, Professor Vian, for that clinical? I think that is what I would. I think that's what I would suggest in that cases. I think in terms of using evoked potentials and further monitoring, it may be a factor in some patients in difficult cases, but the general clinical examination should be enough to decide whether to go ahead or not. Agree, Professor Vian? Do you agree?
Yes, I agree. VP might be helpful, but VP is not very.
Clear.
Yes.
Right.
Sometimes for the patients, the VP, heart patients can find the difference from the VP, but not very accurate, I think, this test.
We'll take one more question from Dr. Liu Bun Singh before we wind up.
Liu Bun?
Yeah, thanks, Raja. Thanks, Professor Ramesh Nair. Professor, you did show us some scan that shows optic canal narrowing due to the fracture, but that is not part of your indication for surgery. May I know that in your cases that you look into the degree of optic canal narrowing to the outcome, whether there's a association with degree of compression of the optic nerve and its outcome, and whether the study preoperative T2 signal in the optic nerve itself and in follow-up, and also the VEP that you may have done, whether that indicate the prognosis of the cases. My last question, Professor, you show that you are using methotrexate more than 3 days, where most guidelines tell us that if it doesn't work within 72 hours, you should not prolong the use. I did your comment. Thank you, Professor.
If you want to answer that, Professor Vian, I think the question was about whether there is any study measuring the optic canal compromise versus the outcome after that. That's your question, wasn't it?
We understand there is a language barrier with our honored guest, but it's okay. We
Yeah,
can have this
but
question
if I make some comments, Boone, I
please.
think I think the Professor Boone's Professor Vian study demonstrated that even with the total visual loss and also with the partial visual loss, you still get improvement after the operation. So whether there is optic canal compromise and whether the degree of ventricular compromise will correspond to further visual improvement, it is may not be that relevant, given that you do see visual improvement in spite of having no vision. And secondly, in terms of seeing signal changes, that may not correlate with the amount of visual loss in many cases, and also the number of cases requiring that VEP or MRI must be very less. And we are in a field where there is no consensus among any of this treatment. So I think it is difficult to say whether such studies will be useful or not.
Right. Thank you very much. It was indeed a wonderful discussion. Can we have your concluding remarks, Professor Ramesh Nair?
Thank you. I think the two speakers, even though I missed part of the first session, both speakers had huge experience in optic nerve gliomas and optic nerve injuries, and I think it's one of the biggest series, Professor Vian's cases, and is published as well in World Neurosurgery. And the results are quite encouraging for us to consider this approach when dealing with patients with optic nerve injury, provided that you select the cases appropriately and make sure that everything is worked up with a proper CT scan, high resolution CT scan, and also in indicator cases, CT angiogram before you attempt endoscopic approaches. And you need, as ever before, for endoscopic approaches, you've got to be well versed in the anatomy of the nasal cavity and the paranasal sinuses and the sphenoid sinuses. So that is all I have to say, and well done, Professor Vian, and that was a great lecture.
Well, thank you very much. It was indeed a great lecture. I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers of today, Professor Shlomi Constantini and Professor Vian, as well as both the wonderful chairs, Professor Ruita Sato and Professor Ramesh Nair, for the time and support for the ACNS webinars. I would like to thank my co-host for today, Dr. Liu Bun Seng, and a special thanks to Professor Shubin for supporting us and suggesting Professor Vian as a speaker. And he has also arranged this WeChat broadcast today in China, where we have more than 1,020 people who have joined us live on various streaming platforms. So until we all meet on the 7th of August, it is bye-bye from all of us. Thank you very much for joining.